organized by United Eastern Medical Services, and we have had the help of Pearl Events, who have helped us to arrange this. I would like to invite our speaker today. We are very, very pleased and honored to have Dr. Abdul Razak, who is currently a consultant in cardiology and internal medicine at Health Plus Diabetes and Endocrinology Center and the Anata Lemarath Hospital. He has over 33 years of experience in many leading medical organizations, not just in the UAE, but also in Syria and USA. And he has a special interest in preventive cardiology and tobacco addiction counseling and treatment. He is a board-certified consultant in internal medicine with subspecialty in cardiovascular disease and is a member of many high-profile scientific organizations. And it is indeed our honor that he is going to talk to us about a very important topic of chest pain. And I hope that it will help all of us to help our patients and treat them and manage them better. So welcome, Dr. Abdul Razak, and the mic is all yours.
Thank you so much, Dr. Neha. Good morning. Assalamu alaikum, everyone. And it's a pleasant Friday morning. And in the next 45 minutes or so, I'm going to talk to you about very important subject, which is the chest pain. I just want to, for technical things, there is middle things about meeting being recorded by the host. Can you guys make that disappear?
Just accept that or...
All right, here we go. So, chest pain is such an important subject. Okay, trying to... It's so important to all specialties. And why so important? Because we do not have luxury to miss the diagnosis sometimes, because it's deadly in so many instances, which I will elaborate on later on. So by the end of this session, I will describe the pathophysiology of chest pain, list the differential diagnosis, and plan treatment of life-threatening causes only. 5% of all emergency visits in the US are related to chest pain, approximately 5 million visits per year. That's a lot. So let's talk briefly about the difference between visceral pain and parietal pain. Visceral fibers enter the spinal cord at several levels, leading to poorly localized, poorly characterized pain, like discomfort, heaviness, dull, aching. That's why the clinical scenario is different from patient to patient. However, heart, blood vessels, esophagus, and visceral pleura are innervated by visceral fibers. Because of dorsal fibers can overlap 3 levels above or below, disease of thoracic origin can produce pain anywhere from the jaw to the epigastrum. It's a very important concept to keep in mind. While parietal pain, in contrast to visceral pain, is described as sharp and can be localized to the dermatome, superficial to the site of painful stimulus. The dermis and parietal pleura are innervated by parietal fibers. Now, please remember this slide. Non-cardiac should be used if heart disease is not suspected. I think we should shy away from the term atypical. It's very commonly used. Doctor, my patient have atypical pain. I think it's very misleading description of chest pain. If you think it's cardiac, you say, I think my patient have cardiac pain. If you don't think it's cardiac, you just say it's non-cardiac pain. And we will try to help you differentiate between both. ABCs. A lot of the time we are so busy, we forget our ABCs. Always look for conditions requiring immediate intervention. Whenever you suspect acute coronary syndrome, go ahead and give the patient aspirin. If you think there's potential ACS, don't waste time. ECG, very basic and very old technology, but very helpful. Cardiac and vital signs monitoring. The patient come to emergency room to your clinic with chest pain immediately. Aspirin, ECG, cardiac and vital signs, and pain relief. Depends on your suspicion what kind of chest pain. We will elaborate on that later on. Because of the wide differential, history and physical will guide the diagnostic workup. History and physical are so important. I think sometimes we jump, do ECGs, look at fancy monitor, but remember, history and physical take you 5 to 10 minutes maximum. Ask the patient about the onset of chest pain. What are the provocation or palliation factors? Quality or quantity, region, radiation, severity, scale from 1 to 10, timing and time of onset. So important to ask the patient if the chest pain started slowly and built up or started suddenly and came down. And also associated syndromes like this patient have diaphoresis, have vomiting, food intolerance, and of course, past medical history, social history, and family history. So important. I mean, for instance, you get somebody who's 30 years old, non-smoker, school teacher is under stress and have some chest pain, come to you, he looks fine. He's non-smoker and no family history of heart disease versus somebody who's 55, diabetic, smoker with hypertension. He looks sick, have chest pain. So I think within history and physical would take only a few minutes, get a clue in which way you're going to direct your differential diagnosis. Physical examination, of course, is not less important than history and physical. Quick physical examination, general appearance. Does he look sick or not sick? I mean, sick-looking person, give you more probability that we're dealing with life-threatening situation. Chest examination, inspection, auscultation, percussion, palpation, and look at the neck. I mean, make sure the good lighting, whether there's jugular venous distension, crepitus, bruit, abdominal examination, extremities, very important, whether they are swelling or pulses or tenderness. Now, what I'm talking about here, different diagnosis. I mean, this slide is very busy. I'm not gonna read it all for you. It is not our job to, like magic, we should know within 10, 15 minutes whether this is cardiovascular, pulmonary, GI, musculoskeletal. But remember, all those systems can produce chest pain. So that's why it's very challenging. So what I will concentrate on the rest of the talk on life-threatening situation, which we cannot afford to miss. Because if you miss, no matter what your specialty, whether you're a family physician or internist or OB-GYN or surgeon, if you miss one of those, patient will die. So we will get clues in the history and physical examination, some initial testing, whether are we talking about acute coronary syndrome, pulmonary embolism, aortic dissection, tension pneumothorax, esophageal rupture, or pericarditis. Now, all other causes, which are another 55 causes, it's okay to delay it, but I don't think we can afford to miss one of those because their patient can die if we don't get a clue how to direct the care. Let's start with acute coronary syndrome. Epidemiology. In typical emergency room, adults over the age of 30, remember, over the age of 30, you can suspect young people, particularly in our beloved UAE. We have very high prevalence of risk factors. We see sometimes people who come in their 20s with heart attack. So any patient come about the age of 30, 15% will have acute myocardial infarction. That's a very high number. 20 to 30% will have unstable angina. So your level of suspicion on patient walk into your clinic or emergency room with chest pain above age of 30 or 25, remember, take him seriously. Now, typical chest pain story, pressure-like, squeezing, crushing chest pain, worse with exertion, with diaphoresis, radiate to the arm. Unfortunately, majority of patients with acute coronary syndrome do not present with those symptoms. Remember this, particularly women. Very atypical presentation. I mean, but if patient does not present holding his chest, leaning forward with diaphoresis and looking sick, doesn't mean doesn't have acute myocardial infarction. Cardiac risk factors, important in getting clue. Is the patient 60 or 70? Does he have diabetes, hypertension, family histories? Is he a smoker? Does he know about dyslipidemia? Whether he used cocaine, which is risk factors. Now, this slide, just if you keep it in mind. As a matter of fact, I don't mind to share my slide to any of you. If you just talk to Dr. Neha and 100%, any of you can take all the slides. Now, to the left of this slide, where is the red mark, If the patient has central pressure, squeezing, heaviness, and so forth, give us higher suspicion of this is cardiac pain, ischemic pain. On the other line, when other side of the screen, where is the green, if the patient have pleuritic pain, positional, when he turn around, has been there for a few days, is not letting up, there's probably low probability of ischemic pain. Now, ECG, very important. All technology was so important. I'm going to start with the last line. 5% of patients with acute myocardial infarction have completely normal ECG. Remember, 5% is high number. So if you do ECG and patient is normal ECG, does not have acute MI. However, 95% of the time, it will show either acute ST elevation infarction, which is ST segment elevation more than 1 millimeter in contiguous leads, or a new left bundle branch block, or patient might have T-wave inversion or ST segment depression in contiguous leads, suggested of subendocardia. What do I mean by that? I'm going to just put a couple of ECGs. This ECG showed normal sinus rhythm with ST elevation in lead 1, lead 2, lead 3, I mean V1, V2, V3, V4, and V5, which mean this is anterolateral ST elevation myocardial infarction. Versus this patient showing ST elevation in lead 2, 3, and AVF with ST depression in lateral lead. So this is acute inferior ST elevation myocardial infarction. Now, enzyme. Ignore everything else. Focus on troponin, please. Troponin is the most sensitive one and is more practical to use. You might order the others, but focus on troponin for your initial assessment. Initial rise of serum troponin within 2 to 4 hours, peak 10 to 24 hours. Very sensitive, very specific. Now, practically speaking, what do we do? Patient come to emergency room, have chest pain, we do history, physical examination, order troponin. First might come negative, so it's not enough. Keep the patient in your waiting area and repeat it in 1 hour. A very common mistake, I would say, some physicians, patient come to the clinic, they order troponin and let the patient go home, and then later on call him back. I think this is malpractice. I really want to discourage all of you not to do so. I think once you have suspicion of acute myocardial infarction and enough suspicion to order serum troponin, the patient should be observed in emergency room setting with monitoring and get 2 troponin, 1 immediately and 1 in 1 hour. If 2 troponin are negative with normal ECG, then it's okay to dismiss the patient and to let him go home. But otherwise, I think is the fact you're ordering troponin, that means your level of suspicion is high, this is ischemic, and patient should not go home and done as outpatient. Okay, just focus on the dotted line for troponin. Initial one can be negative, but within 1 hour start to rise. So it's very sensitive. If 2 troponin are negative within 1 hour, then probability this is not cardiac pain. Echocardiogram. If you are in a facility with the echocardiogram, is very valuable. You do the ECG, you do the first troponin, and then ask for emergency echo. Wall motion abnormalities occur within minutes. It will detect abnormalities in 80% of acute myocardial infarction. Normal resting echo and the setting of chest pain give you low probability of this is acute myocardial infarction. Very helpful test, very easy and very simple. Early screen for complication, aneurysm or valve abnormalities and other structural destructions. Okay, I'm not going to bore you in details of this, but to the left showing, give us a lot of information, whether wall motion and the septum or inferior wall and the apex and so forth. And I can answer you later on if you have any question about this. Now, once you suspect this patient have acute coronary syndrome, as I said earlier, give him aspirin, give him nitroglycerin, give him oxygen and analgesia. If the patient have acute myocardial infarction, ST elevation confirmed by ECG analgesia should be by intravenous morphine sulfate, should not be by Panadol or little pain. And if patient does not have hypotension, blood pressure is okay. Usually we start intravenously, if no contraindication, 2 to 3 milligram and repeat every 3 to 5 minutes, total of 3 doses. So remember, patient come, the comfort given by intravenous morphine sulfate is very important, in addition to nitroglycerin, of course. Additional treatment, beta blockers, anticoagulation, antiplatelets. If the facility have coronary angiography, now majority of patients with ST elevation infarction, if not all, should be referred for primary PCI, so emergency angiography. If you are in a facility which does not have this facility, then you have thrombolysis and refer the patient as soon as possible to primary care center or tertiary care center with angiography facility. Now, briefly, if patient have ST elevation infarction, as I said earlier, aspirin, beta blocker, nitroglycerin, antiplatelet, and so forth. Non-ST elevation can be treated with dose medication and referred for PCI later on. Unstable angina, same situation, risk stratified later on. Now, mortality is twice as high for missed myocardial infarction. Yes, it is commonly used. If somebody comes with chest pain, young patient, 32, normal ECG, initial troponin negative, I'm sorry. Sometimes if you dismiss the patient or they don't take him seriously, or the patient is like female, come with typical symptoms, yes, emergency physician miss 3 to 5% of acute myocardial infarction. 25% of malpractice cost against emergency room physicians in the US originate from this. Single set of cardiac enzymes rarely infused. The goal is to predict likelihood of adverse cardiovascular event by combination of history, physical, ECG, and biomarkers. I really believe if you are careful within 10-15 minutes, careful history, physical, ECG, you do biomarkers, repeat it in 1 hour, I don't think you will miss any myocardial infarction. So not a single globally accepted algorithm. I like this slide, like warranty period. Warranty period, patient come, have chest pain, and by history tell you have normal coronary angiography within the last 2 years, or coronary CT angiography with no stenosis. You can probably, if an ECG is normal and the patient looks fine, you can dismiss him. If he has angiography normal within the last 2 years. If he has stress test within the past year, adequate stress test, also you can probably dismiss him, providing his ECG is normal and everything is good. Now, this is after this brief, we go to the second life-threatening diagnosis, pulmonary embolism. Pulmonary embolism, pathophysiology, caused by thrombosis of pulmonary artery. More than 90% from deep vein thrombosis, which travel through the venous system and lodge in the lungs. Dyspnea is the most common symptom. So yes, patient comes with chest pain, but usually associated with dyspnea in 90% of the patient with pulmonary embolism. Usually it's sharp pleuritic chest pain, a lot of the time associated with syncope. Risk factors, patient have prolonged immobilization, have neoplasm, or non-hypercoagulable disorders. So in your review of system, if your patient, one of those categories come with chest pain and dyspnea, think of pulmonary embolism. Physical examination, tachycardia, diaphoresis, hypotension, hypoxemia, low-grade fever, anxiety, and physical examination, right ventricular heat. Sinus tachycardia is the most frequent ECG finding. It's non-specific, but it is the most frequent one. Classic S1, Q3, T3, I will show you ECG about it, is seen only less than 20%. So if you don't see this thing, does not mean the patient doesn't have pulmonary embolism. arterial blood gases play no role in ruling out pulmonary embolism. And this is again a common mistake some of our colleagues. Hey, we do ABGs, oxygen saturation 90%, or no, that's not the case. Please remember this. D-dimer. In low-risk patient, it can help, but in high-risk patient, does not help us. So yes, low-risk patient with low D-dimer, ECG non-specific, probably does not have pulmonary embolism. So this is the S1, and this is Q in lead 3 and T wave inversion in lead 3. So if patient have S1, Q3 and T3 with chest pain and tachypnea, probably pulmonary embolism. Remember, this ECG finding are less than 20% of the time only. Wells criteria. I don't know if you have to memorize it by heart, but overall, if the patient have clinical signs and symptoms of DVT, this is very important, supportive in your suspicion. Pulmonary embolism, first diagnosis are equally likely. Heart rate, tachycardia, as I said earlier. Immobilization, at least 3 days, or surgery in the previous 4 weeks. Previously objective diagnosis of pulmonary embolism or DVT, that's another important risk factor in the history. Hemoptysis, sometime one of the presentation of pulmonary embolism is hemoptysis, malignancy, and so forth. So it's very important. Treatment, not going to go in details. Unfractionated heparin versus low molecular heparin, or thrombolysis if the patient have cardiovascular collapse. And depends on the clinical scenario, you decide to admit the patient to the floor or intensive care units. Chest X-ray, probably non-specific findings, but sometimes you see elevated hemidiaphragm or partially collapsed lung or increased vasculature. Cardiac echo, very important in massive pulmonary embolism, early signs of right ventricular overload and right ventricular dilatation and pulmonary hypertension. It can happen in massive pulmonary embolism. This chest CT, but don't waste time with your chest CT. I mean, just history, physical examination, ECG, and echo can help you, and then later on you can do chest CT. Now the third life-threatening situation, aortic dissection. Pathophysiology, intimal tear of aorta leads to dissection of the layers of the aorta. Very important. In the history, the differentiation between a chest pain by aortic dissection and chest pain due to coronary artery disease. You tell the patient, did the chest pain start suddenly 10/10 or start 1 or 2 and build up gradually? I think the clue by the history only, if the patient start chest pain very sharp, very high level and radiate to the back, then you think of aortic dissection. If it starts slowly and building up, then probably it's less likely and more likely to be acute coronary syndrome. Risk factors for aortic dissection, hypertension, and connective tissue disease. Examination patient usually have hypertension, pulse differential sometime between upper and lower extremities, and neurodeficit. Radiology, wide mediastinum on chest X-ray and CT angio and echo, which I will show. This is wide mediastinum by chest X-ray. And I think it's important for us. It is not only in examination, I think in real life, I think as internal medicine or family practice to remember the Baker system or daily system. The Baker system, type 1 dissection involve both ascending and descending. But type 2 conformed to the ascending, type 3 confined to the descending. Daily involve ascending type A and type B. What do I mean by this? So this the Baker classification, type 1, ascending aorta, type 2, ascending and arch, and type 3, descending. While daily, if you remember daily, is A, which is involving type 1 and type 2 of the baking, and B involving type 3. It's important to remember because it will help us to guide the diagnosis. If it's the baking type 1 or 2 or type A daily, that means this is emergency referral for surgery. But if the other one, medical treatment and waiting, it's okay. So treatment, patient with uncomplicated aortic dissection, as I said, the distal dissection treated medically, and proximal dissection treated surgically and should be referred to tertiary care center and call the cardiovascular surgeon as soon as possible. We move to the fourth and not least, tension pneumothorax. Tension pneumothorax is lethal if you don't diagnose it. I mean, this is, again, remember, I'm talking about things you do not have luxury to refer next week to cardiologist or surgeon. It's up to you as primary care to have clues how to deal with these things. Tension pneumothorax. It's collection of air in the pleural space, cause collapse of the ipsilateral side, and then cardiovascular collapse. Patient might present with chest pain again. And so keep in mind that. Risk factors, COPD, connective tissue disease, trauma, recent instrumentation, positive pressure ventilation. On physical examination, absent breath sound unilateral. So simple, take you 3 minutes, you hear one lung, the other lung you don't hear it. Hypotension, distended neck veins, tracheal deviation on chest X-ray, then think tension pneumothorax. Why? If you diagnose it correctly, take you maybe total of 10 minutes to diagnose it. The treatment, needle decompression and tube thoracostomy, life-saving, and takes a clue by the careful history, physical examination, and simple suspicion and confirmation by chest X-ray. Now, the next, which is very rare, esophageal rupture. Here in the esophageal leads can to leaking of gastro GI content into the mediastinum, usually caused by inflammation, followed by infection, cause rapid deterioration and death. It's rare but devastating diagnosis. Risk factor, iatrogenic, heavy reaching, trauma, foreign bodies, toxin. Radiology usually mediastinal air on plain film or CT scan. This is a chest X-ray. This imaging. I'm not going to waste much time because this is very rare diagnosis, but think about it. Treatment, antibiotics, supportive care, and surgical consult for all regardless of size. Now we come to the last but not the least, which is fascinating diagnosis, pericarditis with tamponade. It can present with chest pain. Definition. It's a clinical syndrome caused by accumulation of fluid in the pericardial space, resulting in reduced ventricular filling and subsequent hemodynamic compromise. It's a medical emergency. Much of the pressure is transmitted to the right side and to the atrium, which causes bulging of the interventricular septum. So I will talk about this in more detail. It is life-threatening. It's called cardiac compression syndrome, and we need your help as primary care in making the diagnosis and referral for care as soon as possible. If not, patient might die. So again, this is like, it's going to take all of my detective skill. It's really need to be careful. However, if you remember this, Beck's triad, muffled heart sound, jugular vein distension, hypotension. If somebody presents with chest pain, you listen to his sound, you don't hear his sound very good, distended cheek veins, blood pressure is low, think cardiac tamponade. I'm putting again this slide so will stick in our memory. Jugular vein distension, muffled heart sound, and low blood pressure. Now, pulsus paradoxus. in cardiac tamponade during mechanical ventilation. Yes, the name is pulsus paradoxus, but actually it's exaggeration of the norm. So when you with deep breathing, there is more decrease in the blood pressure, usually 5 to 10 millimeter mercury, but with the pericardial tamponade, it's probably 15 to 20 or more. Now, this is electrical alternance. It's very sensitive and very specific sign of pericardial tamponade. Every other beat have different voltage because swinging of the heart. Every other beat had different axis. Just remember this. Usually, it's in most patients with large pericardial tamponade, ECG, you see pulses. We call it electrical alternance. We don't see this sign in many diagnoses. So sinus tachycardia, hypotension, electrical alternance, think pericardial tamponade before you even do your echo. Then chest X-ray showed very wide mediastinum, and then you see echo free space in the cardiac echo. You cannot miss it. I mean, once you think about it, you do chest X-ray, cardiac echo, you get the diagnosis. Large pericardial effusion, evidence of right atrial collapse, and marked elevation of intrapericardial pressure. The right atrial wall will remain collapsed throughout atrial diastole. Usually, this is very advanced case of pericardial effusion and pericardial tamponade. In chronic pericardial effusion due to malignancy or so, you don't see that collapse because the heart takes its time and will accommodate. But usually, patients with pericardial tamponade either have chronic effusion led to tamponade or acute pericardial tamponade. Again, this is another slide. Summarize Beck's trial of hypotension, jugular vein distension, muffled heart sound, and the bottom line of ECG showing us the electrical alternance due to swinging of the heart and changing the electricity every other beat. Why so important to diagnose? Because treatment like tension pneumothorax, immediate attention, and emergency pericardiocentesis. It's life-saving. So, ladies and gentlemen, take-home messages, ABCs, remember them, history, physical examination, and have very low threshold for missed MI. I really think every patient who have high risk, multiple risk factors, smoker, diabetic, hypertension, positive family history, overweight, and coming with chest pain from the waist to the neck, we should think of ischemic heart disease. Remember, I'm not going to be like in acute coronary syndrome, you have diaphoresis, tachypnea, tachycardia, hypotension, crackle, so forth, pulmonary embolism, tachycardia, dyspnea. Patient come with chest pain, tachycardia, and dyspnea, I think pulmonary embolism. Aortic dissection, somebody hypertensive, have connective tissue disorder, come with severe chest pain, start suddenly very high and then go lower. Think of aortic dissection. Now, the last three slides, maybe it's hard to read for you guys, but if you want to borrow the slide, this is very important. So this slide telling us chest C for chest pain means more than pain in the chest. Seriously. High sensitive troponin preferred. Lab, very single, very sensitive. Do it twice. When patient arrive on 1 hour later. Then both normal ECG, you can dismiss the patient. E for early care. Seek early care of acute cardiac syndrome. Give aspirin and put patient on monitor, give oxygen. If you confirm, then you do the rest. Share the decision making with your colleagues. And really, if somebody is low risk, you don't have to overtest. Somebody come who is 20 years or 18 years, have chest pain, is non-smoker, and ECG is fine, and the history does not suggest coronary artery disease. You don't have to go through markers and echo and all these things. P for pathway, use clinical decision pathways. A for accompanying. Women may be more likely to present with accompanying symptoms and usually have atypical symptoms. Usually they come late. Usually they do not, they're not taken seriously, unfortunately, by their family members or by some of the health caretakers. So be special attention to women who come with symptoms were not there before. I identify patient most likely to benefit from further testing, and non-cardiac, don't talk typical chest pain anymore. Say, and for non-cardiac, this patient, when you discuss with colleagues, have cardiac versus non-cardiac, and so forth. So these are my references, and thank you very much, and we'll be more than happy to entertain any question you might have.
Thank you so much, Dr. Abdul Razak. That was really very, very extensive, and it covered so many causes of chest pain. And I think it will really help people in the A&E and in the primary health centers as well, because very often we do see patients coming in with chest pain, and as an OB-GYN also very often, and it is very confusing at that point of time what to take seriously and what not to take seriously. So that is some very good pointers there, and we are very glad that you're always there, so we can always ask our patients to see you quickly. It has been very, very, I think, useful, all the information that you have given. For the participants, we are posting a post-lecture assessment and an evaluation form link in the chat box. You can go ahead and complete those surveys. And if you have any questions for Dr. Abdul Razak, you are most welcome to either post it in the chat box or raise your hand, and he will be more than happy to answer any questions, any doubts, anything related or even slightly unrelated. So already we have a question, Dr. Abdul Razak. So the question is, what are the reasons why a 42-year-old female is having T inversion and no symptoms at all, despite the fact that all the blood chemistry, treadmill, and 2D echo are all normal? Only thing is the family history of type 2 diabetes and no history, and hypertension, I think they want to say, but no history of heart disease.
This is very important and very common reason for referral. Somebody come in with some kind of symptom and have T-wave inversion. And T-wave inversion, very non-specific findings in ECGs, whether female or male or any age. If usually with somebody who we suspect, we go for echocardiogram. If resting echocardiogram is 100% normal, then we go for exercise stress testing, either plain exercise testing or with imaging. So by this T-wave inversion by itself, then we can reassure, and this we call it non-specific T-wave abnormalities, if the echo is normal and stress test is normal. I hope that answered that question.
Yes, I hope so, but I don't know who is the person who have asked by the initials YD. If you want to ask anything more on that, you can unmute yourself and ask. Okay, I think they have a comment. I'm just waiting for them. So they're asking, what is the reason about it?
Well, you see, the electrical abnormalities in the heart, it's very complex to discuss in details now, but in general, if the patient have hypertensive heart disease, if the patient have early cardiomyopathy, if the patient, there are so many causes for cardiac abnormalities. However, we do see sometimes somebody with 100% normal heart, who does not have hypertension, does not have cardiomyopathy, and yet we see some T-wave inversion. Usually, those T-wave inversion are not deep, they are not symmetrical, and they are not dynamic. You see, T-wave inversion, if it's dynamic change from time to time, it has more pathological meaning. But if it's fixed, minor T-wave inversion in 2 or 3 Ds, and usually it's just simple normal variants.
Okay, so I think that should be clear that it could be a normal variant, and Dr. Abdul Razak has given what other tests and further investigations you can do. I think they're satisfied. There's a thank you message from, I think no reason to get worried is what they're saying. Okay, excellent. So any other questions? Dr. Abdul Razak, in OB practice, we often find women, especially in the third trimester, they have heartburn and they often present as, chest pain. But if their vitals are normal and if there's no other symptoms, then do you think a young pregnant lady should have full evaluation, or do you think we can observe and
No. Young female pregnant with heartburn in their third trimester, I think without other risk factors, I think reassurance and symptomatic treatment is more than enough. I don't think that's not even a cause for referral, unless the patient is very much worried and positive family history, some other risk factors. But in general, no, I totally agree with you. Just reassurance and observation. Most of the time, after delivery, those symptoms disappear.
Mm-hmm. Right. So there's one more question from Raquel. Are there any non-cardiac causes of chest pain, and do they need to go and see a doctor in that case?
Well, exactly. That's what I've been talking about the last 45 minutes. There are some other non-cardiac causes of chest pain. And this could be GI, could be pulmonary, could be musculoskeletal. And after we rule out the cardiac causes, then a patient can be referred to other specialties.
Yes, I think what I've got from the presentation is that we have to look at the complete picture. And if we think it could be cardiac, then it's always better to rule that out with all the tests and steps that you have described. But if it is not that, then we have to think of all the other non-cardiac causes as well.
I see a question about the axis deviation.
Yes, there's one question about that. What is axis deviation and who it presents and on ECG, and what are the different changes in EKG?
I tell you something. Let me summarize this important question by the following. If the patient have complete left bundle branch block, we cannot read ischemia. This will mask any ischemic abnormalities. Any other axis deviation, then it should not mask. We can still read ischemic changes. Somebody with right bundle branch block, right axis deviation, left axis deviation. If the QRS is little bit we call it non-specific intraventricular, we can still ischemic ST2 abnormalities. So, but with complete left bundle branch block is the only one which can mask ischemic changes, then we should look for wall motion and look for, however, if somebody come, as I said earlier, with severe chest pain with new left bundle branch block, he should be treated as acute myocardial infarction. Okay.
Okay. There are some more questions being posted. The question from Juvie, if I feel chest pain for more than an hour after taking Plavix, shall I need to take 2 more following Plavix with 10 milligram of Inderal?
No. See, beta blocker, you give it depends on the situation. Most of the time, the patient will need beta blocker as treatment if there is no contraindication. Be careful with the acute inferior myocardial infarction who come with heart block or bradycardia with hypotension. But otherwise, this is the answer for beta blocker, whether it's Inderal or Lopecer or anything else. Now, what if more than 1 hour? What was the question again? I mean, if patients have chest pain more than 1 hour?
More than an hour after taking Plavix,
No, you don't give another dose. No, you give Plavix. Patient have chest pain. If the patient have ischemic changes, and then you are in a tertiary care center, patient have be seen by cardiologist, go to the cath lab. Or you can put him in emergency, take him to a second in Abu Dhabi. Within 10 minutes, you can reach another hospital. So you treat him with the oxygen, nitroglycerin, you give him analgesics, you give him a beta blocker and transfer.
Okay, so that's clear. There's no point trying with more medicines where you are transferred to a...
You don't give more. No.
Dr. Ibtihad says, wonderful presentation. Thanks a lot. There is another question from Sana Omran. If there is inferior wall MI, can we give nitroglycerin?
Well, we are very careful. That's a very excellent question. Usually inferior infarction, are very sensitive to nitroglycerin. If the blood pressure is okay, we give nitroglycerin and monitoring the blood pressure. But most of the time, inferior infarction is associated with hypotension. So volume, if patient is not in heart failure, you give him normal saline and give very low, if the blood pressure is okay, you give very low dose of sublingual nitrate and observe. But usually they tend to get hypotensive. So be careful with nitrate in the setting of inferior myocardial infarction. That's a very excellent question.
Okay, so that's clear. There's another question from Musahid Turi. Do we need to give oxygen in acute chest pain, ACS, sorry, even if saturation levels are well within normal limits?
Yes, low flow oxygen is indicated in every patient who have acute coronary syndrome. Yes, I mean, regardless of the oxygen saturation, give 2 to 3 liters per nasal canal.
Okay. And there's a question by Zahid Hussain. Which antiplatelet gives good results and how many days can be continued in AMI?
Well, aspirin should be given to every patient. If the patient have ST elevation infarction, then giving also additional Plavix immediately and then go to the cath lab. If the patient have acute coronary syndrome, unstable angina, or non-ST elevation function, you give aspirin. You might even give Plavix, and depends on what they find in the coronary angiography. Usually, if they do intervention, usually we give additional antiplatelets for 1 year following the intervention, then continue aspirin for life. But there are criteria, if more than multiple lesion, very high risk patient, sometimes we give Plavix indefinitely.
Okay. Thank you for that, Dr. Abdul Razak. There is one question here about a case where someone has recurring chest pain. ECG has been done 2 to 3 times and it's normal. You suspect gastritis and H. pylori test is also done and normal and negative. What can be the causes of chest pain?
Well, this patient need to be seen by cardiologist. Then we can do the echo, do stress testing with nuclear imaging, and then rule out cardiac pain. I mean, then if everything is normal, then decision, we go through the first slide, the very busy slide. Is this GI? But he said GI was negative. Is it musculoskeletal? Is it pulmonary? Is it other things? But if you rule out the cardiac causes and pulmonary causes and then GI causes, then maybe musculoskeletal.
Okay, so there can be multiple causes, and I think you've ruled out 2 in your case, but even then a cardiologist opinion I think would help, because we can look at other causes of chest pain that are not necessarily picked up by ECG, right, Dr. Abdullah?
Absolutely.
Excellent. So I think if there's now more comments than questions about how informative and inclusive this presentation was. So that is what most people are now writing. But if there's any more question, we still have a few minutes where we have Dr. Abdul Razak with us. If you want to ask anything about your experiences or queries with managing chest pain, Marinette says, thanks for the explanation, Doc. And I'm just trying to see if there's any more question. If anybody would like to say anything, ask anything, please go ahead. We still have some time. Okay, there's one more question from Zahid Hussain. Does hiatus hernia cause any ECG changes?
I wouldn't say so, no. I mean, sometimes it's very unlikely. Very unlikely, no.
Okay, so that's clear. Then there's one more question from Dr. Anusha. If someone presented with chest pain and had normal EKG and non-cardiac causes are also ruled out, should they be followed up? Like, should they be asked to come back for a follow-up checkup, and how frequently?
Certainly. I mean, all the patients with chest pain should be come for follow-up with their general practitioner or internal medicine. I mean, if their cardiac workup is negative 100%, and depends, I think the role of the primary care to take care of the risk factors and reassurance and look for other causes. And we cannot just tell the patient, your heart is okay, no more follow-up. I think reassurance that the chest pain is not coming from the heart, give him comfort. I think the cardiac phobia and the fear of death need a lot of reassurance. I think some people get even depression, anxiety, they cannot perform because they're afraid every time they chest pain is from the heart. So once they are reassured not from the heart, I think the reassurance and care and routine follow-up, the primary care is so important. Every 3 months or 2 months, depends on the situation.
Thank you so much. There is a comment from Dr. Khadija that it is a wonderful presentation and cleared all doubts. Thank you, Dr. Khadija, for attending. Yes, so just basically now, most people, Dr. Anusha, Lynette, are thanking you for an excellent presentation and that you've covered almost everything. Just waiting for any other questions, Dr. Abdul Razak. So just one last, I think, what I would just like to ask you, if you can summarize, in primary care on A&E, when a patient with chest pain presents and we are referring to a cardiologist, what do you expect from us? Like, do you need us to first do an ECG and transfer, or just transfer?
No, I really think ECG is very important part in initial assessment. I think history, physical examination, ECG. If all normal and patient stable enough, then transfer. But the additional point, Dr. Neha, I want to emphasize that the risk factors should be all screened by the primary care. Even if you don't complete it, have the patient come back and take care of their obesity, their hyperglycemia, their dyslipidemia, and smokers. Again, I'm giving a talk this afternoon about tobacco. I think it's very unfortunately neglected. I think sometimes we ask the patient, do you smoke? And then we don't even comment on that. And we don't have time. The insurer doesn't pay for it. It's major risk factors. And I think if you we call it 30-second approach. Do you smoke? He said, yes, I do, but I cannot get rid of it. He said, okay, how about if you think about quitting and we can refer you for tobacco cessation at some point. So just give the patient opportunity and hint that it is a very important risk factor and need to be taken seriously at some point. The same thing, somebody with overweight, we cannot assume, well, this lifestyle, he have to eat and he's overweight, bye-bye, go to the doctor, cardiology, chest pain, or the heart, and go on. I think the follow-up with you after consulting with the cardiologist, so important to take care of the risk factors, as I said earlier, tobacco, diabetes, hyperglycemia, dyslipidemia, immobility, anxiety, all these things. So it's very important to engage the patient about the prevention, not only rule out chest pain and go back to the community and get heart attack a year later.
Yeah. Thank you, Dr. Razak. I think that was a very good message for all our primary healthcare providers and A&E doctors. Just a few more questions that are being posted on the chat box. Raquel wants to know, what can you tell to patients who are non-compliant with their medicines and think they are fine, but they are not?
Well, usually those patients I share. I said, we don't, you see, we have to avoid pointing fingers and make the patient feel guilty. We tell them, well, your blood pressure is high. What do you make of that? What do you think is that? Your weight has gone up. So I need your help. What's going on? For instance, he's not taking his cholesterol. You give him correct medicine, but he's not taking it for the past year. Tell him, would you please be able to tell me why you're not taking the medicine? Sometimes the cause is financial, sometimes it's inertia, sometimes ignorance. So if you engage the patient, inform him that these are risk factors and he should consider it, and it's up to him to take care of those risk factors. I usually involve the social story. I ask a patient, how many children do you have? He said, I have, for instance, 2 daughters and 1 boy, or whatever. Then at the end of the story, I said, okay, I tell you what, our goal is to do our best that you live healthy and long enough so you can enjoy seeing your children grown up, and to prevention. And you can tell the patient those risk factors are risk factors, they're silent. And it's so important, if you want to live long, enjoy life, see his grandchildren, to consider taking care of this. So we avoid to tell them, you take your medicine, you're not doing the right thing, you should quit. I think all of these things will patient will have more anxiety and he will dislike you. So we'll engage him in a positive way, inform him. The best patient is the well-informed patient.
I totally agree, Dr. Razak. That is really very good and very good tips there, because we often face such patients who are, sort of in denial also. So just a few more questions coming up. Zahid Hussain wants to know, why is the MI painless in type 2 diabetes, and how can we diagnose such MI?
So such important questions. See, diabetes causes neuropathy. And part of the neuropathy is neuropathy of the heart. See this, the pain, because a lot of things happen in the diabetic is painless. So some diabetic patients come with atypical symptoms, dyspnea, fatigue, palpitations, diaphoresis, heart failure. Then we go through this ECG, echocardiography, we do assessment, even if it's totally painless, sometimes we diagnose severe coronary artery disease, refer them for surgery or PCI. So yes, the suspicion is there. As I said in the first slide, history, somebody he's in his 30, above age of 30 or 40, diabetic, come with a typical symptom, you do ECG, echo, refer for stress testing, and then you can make the diagnosis.
Okay. And one question from Zahid Hussain again, can cervical rib cause referred chest pain?
Absolutely, of course, of course. I always tell them, from the skin to the heart, there are 8 organs. So rib fracture, of course, is one of the major causes of chest pain. So history, I said trauma. So history involves trauma. Somebody punched him, or he fell out of tree, or have car accident, and you examine and you do X-ray. Of course, can cause chest
pain. Okay. Thank you so much, Dr. Abdul Razak. I think that we will have to stop here. I'm sure there are many more questions, and Anit can just post the link of the email of Academic Affairs. And if anybody has any questions about this or wants to ask Dr. Abdul Razak anything, you can email to us, and we'll try and forward it to him and get back to you. I think everybody has really enjoyed. There are lots and lots of comments of how informative it was, and how it covered almost everything and cleared their doubts. So thank you so much, Dr. Abdul Razak, for being with us, sharing your knowledge, your experience, and giving us tips and practical tips on how to deal with this situation. So thank you, and thank you everybody who's attended. Thank you, Zainab, Cherry, for arranging from the marketing side. Thank you, Anit, for organizing as always and helping. Thank you, Mr. Shamali from Pearl Events, for helping us to put this CME together. And thank you, Dr. Abdul Razak. If anything else you want to say?
I just want to really summarize. I will say really this one of the most enjoyable talks I gave. I felt the engagement, the interaction, and I want to really, again, special thanks to you, Dr. Neha. I mean, mashallah, you're doing such an excellent job, and you're on top of things, and the way you communicate, and of course, the team around you, I think make us all proud to be part of this UE medical organization. Thank you so much, and thanks for all attendees.
Thank you. Bye-bye, everybody. We'll see you next week with another CME. Thank you. Bye-bye.
Bye-bye.